s'il vous plaît, accueillir professeur Lynn Gauthier.
I want to start by asking you to imagine having to decide between treating your cancer and treating your pain. Now, fortunately, treatments for cancer have become pretty sophisticated, which has improved the survival rates for many of cancers. But unfortunately, many of the treatments that are meant to cure the cancer can also cause chronic pain. Tonight, I'm going to be telling you about one very poorly understood type of cancer treatment-related pain called chemotherapy-induced peripheral neuropathy, or I'll be calling it CIPN for short. CIPN is a term that represents a constellation of sensory, motor, and autonomic symptoms. It's characterized by a stocking and glove distribution, with the longest nerves affected first. So what this means is that symptoms start off first in the toes, and they move into the feet, and up into the ankles, and then into the legs, and in the fingertips, and then into the hands, wrists, and arms. Some people experience symptoms in the face. These symptoms can feel like burning, shooting, cramping type pain. People can experience pain from stimuli that's not normally painful, like a light touch or touching something cold. Some people experience symptoms that they don't necessarily describe as pain, but more weird symptoms like tingling or numbness or pins and needles. People can also experience weakness in their arms and legs. These symptoms have a tremendous impact on well-being and quality of life. Altered sensation can lead to things like injuries, like burns, because you can't tell when something is too hot to touch. The altered sensation, as well as the motor weakness, could lead to other injuries, like balance difficulties leading to falls and injuries like a broken leg or a broken hip. The symptoms can also impact on well-being in other, maybe less dramatic ways, but add it all up, have a huge impact on quality of life. For example, people lose the ability to drive because they can no longer sense the brake and gas pedals. They also have a hard time cooking for themselves because touching hot and cold things causes tremendous pain. It's very common. More than 60% of patients experience these symptoms while they're undergoing treatment with certain types of chemotherapies and immediately after treatment, and up to 30% of patients experience chronic CIPN, so for them it never goes away. There are no cures for CIPN, there's no way to prevent it, and there's only one medication to treat it, but it doesn't treat all of the symptoms, and so as a result, it's not very commonly prescribed. Now here's the critical part. In 2 to 65% of patients who receive certain types of neurotoxic chemotherapies, the symptoms and their impact on functioning are so bad that they have to get less chemotherapy than prescribed. They either receive a reduced dose of chemotherapy at each infusion, or they have to stop their treatment early altogether. And in fact, because there's no way to prevent CIPN or really to treat it, this is really considered the primary way to manage CIPN. Now, this is a problem because receiving less chemotherapy than prescribed could have an impact on the effectiveness of the chemotherapy to treat the cancer and ultimately someone's long-term survival. But we don't know if receiving a lower dose of chemotherapy or stopping treatment early altogether will cure the CIPN or even stop its progression. So there may be some real uncertainty about the decision to receive all of the chemotherapy to treat the cancer or to receive less of it to treat the pain. Now, you may be thinking that because of the importance of this decision, that there may be some really clear guidelines about when this decision needs to be considered. But in fact, the guidelines for the prevention and management of CIPN only state that clinicians should talk to patients in the event of intolerable neuropathy and/or functional nerve impairment. But they don't tell us what these things mean. So people are faced with this really important decision, but they don't have any tools to help them decide. And you can imagine that if you don't have good tools, or really any tools at all, to help you make this decision, it's really hard to make an informed, values-based decision, or one that is consistent with what you want for your health care. You can imagine that how do you prioritize the choice to live an extra year of life with really debilitating CIPN against the choice to experience your family life in the way that you want to experience it, like having the strength in your arms to lift your grandchildren up. So I want to ask you again to imagine having to decide between treating your cancer and treating your pain, where there's so little information about how to make this choice. It's a little bit like navigating in the fog without having a lighthouse to guide you home. And you might expect that we would have a really good understanding about what factors are associated with needing to have one of these treatment changes. But to date, the research has really only focused on a certain small number of potential predictors of needing a treatment change to manage your CIPN. And so far, this research has really just focused on the type of chemotherapy and a certain number of demographic and clinical factors like your age or whether you have other chronic conditions like diabetes. But other factors may be important. And we know from the larger chronic non-cancer pain literature and cancer pain literature that CIPN as well is associated with biopsychosocial factors, such as whether we have other chronic conditions, our mood, the meaning we attribute to symptoms, and the support that we feel is available to us. But no one has ever looked at how these biopsychosocial factors are associated with the decision to alter chemotherapy to treat CIPN. So my lab has started to ask these types of questions to understand how these decisions are made, under what conditions, and for whom. And we started with the latter two questions by asking what factors are associated with a CIPN-related dose reduction or early discontinuation of chemotherapy. So this was a study of women with early-stage breast cancer who were undergoing taxane-based treatment for breast cancer. We met with women just prior to the first cycle of chemotherapy and then immediately after the last cycle of chemotherapy. And women completed measures, self-report measures of neurotoxicity symptoms, so those weird symptoms I described earlier, like numbness, tingling, and pins and needles. They also completed measures of neuropathic pain, hot burning pain, cold freezing pain, pain caused by light touch, things like that, as well as non-neuropathic pain. They completed measures of mood, quality of life, the meaning of symptoms, and they underwent something called a quantitative sensory testing procedure to understand their sensation and pain threshold to different stimuli, like cold and hot, vibration and touch, on the hand and on the foot. So in this study, 38% of the women needed a CIPN-related dose reduction or early discontinuation. And we found that the factors associated with these treatment changes were biopsychosocial. So the first factor we found was the type of taxane molecule. Just briefly, within the taxane family, there are two different molecules. One is called paclitaxel, the other is docetaxel. We know from the literature that paclitaxel causes worse symptoms, it's more dose-limiting. So this was not really a shock to us. But we also found that high post-treatment neuropathic pain and cold sensitivity in the hands were associated with needing a treatment change. So these two findings tell us that patients report that their symptoms are intolerable or their healthcare providers are interpreting them that way when they reflect neuropathic pain specifically. So in addition to the weird sensations I described earlier, numbness, tingling, and pins and needles, there needed to be a neuropathic pain component, hot burning pain, cold freezing pain, pain caused by light touch. And cold sensitivity in the hands, but not the feet, suggesting that altered sensation in our hands may have a greater impact on our daily lives than altered sensation in our feet, or our healthcare providers are interpreting them that way, leading to a treatment change. But perhaps the most intriguing finding from this study was that low scores on a measure of pain catastrophizing were associated with treatment changes. Now, this is completely counterintuitive based on what we know about this measure of pain catastrophizing. Catastrophizing is a way of thinking about and reacting to pain that's characterized by rumination about pain, magnifying its negative implications, and thinking that nothing you can do is ever going to make this pain any better. Normally, in studies of people with chronic non-cancer pain and cancer pain, catastrophizing is usually associated with worse pain. So we would have expected in this study to see catastrophizing associated with such intense CIPN that people needed a treatment change, but we found the opposite. Because these decisions rely on communication between the healthcare provider and the patient, we have to think about how communication plays a role in these decisions. And we know from one model called the Cancer Threat Interpretation Model by Lauren Heathcote that the meaning people attribute to their symptoms plays a role in their behavior, and perhaps in this case, in symptom reporting to healthcare providers. And we also know that catastrophizing is associated with cancer-related worry. So it may be possible that catastrophizing here really reflects people's worry about telling their healthcare providers about their CIPN symptoms in case it results in a treatment change that may affect the effectiveness of the chemotherapy to treat the cancer and ultimately their survival. So as you can see, these treatment changes are not simply a function of just the intensity of symptoms, but there are a whole host of biopsychosocial factors that may be important, specific conditions by which it may be happening, and to whom, based on people's thoughts and feelings about their pain. Now, because of the importance of this decision, you may expect that we might know a little bit about how these decisions are made, but I can tell you that there is no research examining how people are making these decisions. So my lab is about to launch a study where we're going to look at real-life situations to understand, see, and hear what is actually happening when patients and their healthcare providers are having these discussions about needing to make a treatment change. And although this research is really in its infancy, I hope that the knowledge that we eventually gain from this research will help us to develop some tools for people that will make it easier to make these decisions that are informed and get grounded in people's values about their cancer care and their pain management. Thank you.